All right, everybody. This is Dr. Ed Park. Thank you for joining us for another live webinar. Today we'll be talking about hip problems. So the hips are often affected in many age ranges. It was hard to get exact number, but I think the problem is that we're talking about the weight-bearing complex. It's the grand central station of our body. Our body moves through the hips. Its weight is borne through the hips, so there's a lot of stress there. There's complex interactions with your posture. Bad posture causes hip problems, and hip problems cause bad posture. We'll get into that. We'll talk about the anatomy, and we'll talk about these repetitive stress injuries also. Um, the paradox with this, and I think this comes out in Colleen's story a lot, is that you got to use it or lose it. A lot of people think, well, I need to exercise more, and then that will make the pain go away. Well, sometimes if you're exercising and causing repeated damage without time or the ability to heal, that's not the case. So, on the other hand, we have Deb from last week's knee webinar. She couldn't really do one squat, and since then she's done 37,000. In her case, using it was making it stronger. So, it's always a fine line between using, strengthening, balancing, and preventing injury. Of course, when we look at this gymnast, he's going to become this old man with a sore hip. And why does that occur? It occurs because of injury, aging, arthritides. Of course, there's the regular run-of-the-mill wear and tear. We call that osteoarthritis, which is very related to osteoporosis. The bones, after all, make the cartilage. But there's also, as we'll discuss, weakness or imbalance of the musculature. Um, there's many arthritides. There's an entire field called rheumatology devoted to that. We can't go into that now, but that obviously, there are many things that can cause secondary arthritis. We go back to the octagon because the octagon reminds us that there's one disease with many faces. What I mean to say is that on the outside, we have all diabetes, weak immunity, wrinkles, cancer. All these things can be attributed back to dysfunctional stem cells, which can be caused, and I think are caused, by depletion, deterioration, mutation, and epigenetic silencing of these stem cells. And of course, we are made up of cells. So your cartilage, your bone, your ligaments, your muscles, your tendons, everything is made up of cells. Okay, so what is the hip? The hip is always, when I was studying artificial general intelligence, I used to think about this word hip because it's so fuzzy. And when people say fuzzy language, they mean that the language is ambiguous. If you look up hip in the internet or the dictionary, one of the prominent references is to roofing. This is a red square hip. If the roof, let's say, were cut on the top, it would be a half-hipped roof. If you have gables, these yellow side panels, in other words, the roof does not go all the way down, it's not a hipped roof fully, it's got gables. Who cares? I'm just saying. I guess they call it a hip because the top meets the bottom, but this is a common term, the hip. There's also a hipster. This gentleman perhaps is contemplating the deeper meanings of life. He's advanced in his culture and his thinking, or at least he thinks so. That's a hipster. I'm hip. So a great song I got to hear play live. It was, if I was doing videos, I would put it in there. I'm hip. It was a really great song, I think, by Dave Frischberg. Anyway, the hips are also part of the measurements: the bust, the waist, the hips. So in this Grand Odalisque, this is an ideal of beauty. She has ample hips, skinny waist. It's thought, as by anthropologists who love thinking about these things, that the thing that makes the hourglass figure attractive is you have the breasts to feed the child, and you got the wide hips to birth the child. Because as people who are evolving, the rate limiting step is how big, how smart a head can you get through that pelvis. As an OBGYN, we love to see the gynecoid pelvis, and that means that the inlet is nice and round. The baby can come through. If the woman had narrower hips, especially in the inlet, it's a heart-shaped pelvis, or android, male-shaped pelvis. That's not so good. And of course, now we have the C-section. That helps. But even with the baby's head being soft, unfused, it comes out shaped and molded. Within 24 hours, it'll go back to a relaxed shape. But this is the rate-limiting step of humanity. So the fuzzy language tells us that people use the word hip in a lot of different ways. It's confusing. But the hip, or in Latin, the coxa, plural coxae, the hips are a joint. They're a bone, a fusion of three bones to make one bone. They're a region in your body. Oh, my hips hurt. Where do they hurt? And we'll go into that, as well as a function. So we see on the far left here, the green is the sacrum. That is not the hip. It is part of the pelvis, but it's not the hip. The hip is these three fused bones, the purple pubis, the sort of mauve ischium, and then that winged ilium. These three fuse and they become a single hip on the left, which is colored, and a single hip on the right, which is white. A person might come to you and say, oh, my hip hurts, on the side, or on the side, or it's kind of in the front. So the hip is a region. And then finally, the hip is a function. What do I mean by that? Well, if you look at the way they talk about gait or walking, you see that 40% of the time you're in what's called the stance phase. That means the blue leg is bearing weight. 40% of the time, the blue leg is swinging, not bearing weight. The beginning of that is the heel strike, and that's a moment when you have double support on the left. And then in the middle, the other 10% is when you're pre-swing, and again, you have double support. So this will kind of become relevant as we talk a little bit about the hip function. So the hip is a joint. It's a nice ball and socket joint. Sometimes the ball can be too deeply rooted. That's a problem too. That has a Latin name, which currently escapes me. But basically, there are 6 motions. We have to go through all 6 motions real briefly here. So there's hip flexion. That's the first step of the hokey pokey. When you put your right foot in, actually you put your whole leg in, and realize, I think it's important, I started to grasp this as I was reviewing for this, that just because you're flexing your hip, the real action is on the standing leg, yeah? So the standing leg is doing all things are firing, both in the, just to maintain your posture, and we'll get to that in gait disturbances. So the right hip flexes. The main flexor is the iliopsoas. The iliopsoas is shown to my left. That's that powerful green muscle that we talked about in webinar 2, often implicated in back pain. You can see here why, because these muscles powerfully contract, and they can pull that spine out of alignment, and that spondylolisthesis can cause curvature. So excessive psoas muscle strength or asymmetry causes back problems. We also have the iliacus, which is that lining on the inside of that clamshell, if you will. So the iliopsoas come together, and they insert on the lesser trochanter, or the inside of the thigh. These are powerful hip flexors. Okay, a hip flexor is also something that prevents the torso from falling backwards. So you can imagine if that green thing is firing, your torso can't fall backwards. Okay, so the other flexors are the rectus femoris. That's the one quadricep that goes all the way across the knee and the hip joint. And we have the sartorius, and we have the tensor fasciae latae as well. So if the hip flexors are free from falling backwards, if they're damaged, what you have is this walk shown in this gal above. What she's doing is the right side is damaged, so it can't bear weight properly. What she'll do is circumduct it, swing it around in a very fast motion, and then she'll have to lean on her good leg, lean back and lean away. And she'll kind of do a short stride on that side. Weak hip flexor on the right, you're going to do this. You're going to circumduct your leg. Okay. The rest will be a little quicker. So the hip is also extending. You put your right foot back, that's extension, okay? The hip is extending. The muscles we talked about last week are the semitendinosus and membranosus. Those are the inside or the medial hamstrings. And then on the lateral side, there's the biceps femoris. And all 3 of these will insert on the ischial tuberosity. That's that bony eminence that you're sitting on. Also, a powerful hip extender is the gluteus maximus, which extends mainly on the iliotibial tract, or that band on the side. The extensors, in contrast to the flexors, they prevent the torso from falling forward. So you can imagine those hamstrings, if they're contracting, then the pelvis and the torso won't fall forward. Okay? So this is important in the stance phase. If you have a damage to this, then the torso will have to lean back like this Grateful Dead Keep on Trucking guy. A person with a weak gluteus or hip extender, they won't be able to support their weight, so they'll have to lean back when the heel strikes and the stance begins. The hip can also be an abductor. How do we remember the difference? Well, remember Young Frankenstein, the assistant got the abnormal brain to put in. Abi is away from. That means not normal, away from. So what we see here above me are 2 sets. The abductors, they'll do the top motion. They'll lever over the top and make that leg go out to the side. The adductors make the leg cross over or towards the midline. The primary muscles that do this are the tensor fasciae latae and the deep gluteal muscles. This is the glute medius and the glute minimus shown in the cartoon. Next to me is the Trendelenburg sign and the Trendelenburg gait. What this means is if you have that, see that next to the X, there's that lesioned muscle. That muscle can no longer prevent the torso from falling inward. So what does that mean? It means the pelvis will sag and the person will compensate by leaning their body to that affected side. Okay, sagging pelvis, leaning towards affected side. That's the Trendelenburg sign and gait. This famous meme tells us what adduction is. Adduction is reminiscent of the word advertising. Advertising means towards turning. It's something to get you to turn towards, like this man who is apparently dating one lady who looks just like the other lady, except she's wearing a red dress. A commonly used meme on the internet these days. So again, looking above, a adduction towards the center are these powerful muscles that allow the skeleton to cross its leg. Here they are in the cartoon to our left. We have the pectineus, a strong muscle. We have the adductor brevis and longus. We have the adductor magnus, and then we have that finer gracilis. If a person has weak hip adductors, they will again circumduct their leg, meaning that orange damaged leg will swing around every time they do a gait cycle. The final two motions are external and internal rotation. In the black and white cartoon above me, the physician is demonstrating lateral rotation. What that means is at the hip socket, the hip is turning out. Okay, so remember the rotator cuff webinar, we did shoulder. So the shoulder reminds us that if the subscapularis on the upper left is on the front side of the shoulder blade and inserting on the front of the bone, that'll internally rotate. The more commonly injured ones are the infraspinatus and the supraspinatus on the back of the shoulder blade, inserting on the back of the humerus, allowing for external rotation. Yeah. So analogously in the leg, we see to my left a cartoon. The gluteus maximus is a powerful external rotator. If you peel it back and look here on the right side, we see the others. Again, the glute medius and minimus can kind of do it all because they're in that central position. But the specified ones, the specialized ones are the piriformis, which we talked about in webinar 2, causes back pain. Sciatica, mimics back pain. And then we have the superior and inferior gemelli, the obturator internus and externus, and then this quadratus femoris down there below. This is the external rotation group. Finally, there's this cool little muscle that the bodybuilder is demonstrating. That's the sartorius. I guess it's called that, they think, because the tailor, sartorius, used to cross his legs. I don't know. But that goes from the outside of the pelvis to the medial tibia, and that'll allow you to cross your legs or externally rotate at the hip. Final sixth motion is internal rotation. This is just like, it's the same muscles as the adductors, basically. So we have the gluteus medius and the gluteus minimus, and the tensor fasciae latae in this case. The doctor above me is demonstrating internal rotation. You can see next to me, looking down from your face to your sneaker, you can see that the angle of the neck of the femur can vary in its position, and relative to how the muscles are attaching is how much internal medial rotation you'll get. All right, so that was the anatomy review. Let's talk about the hip or the coccyx as a bone, your hip bone. What does that mean? Let's make it a little less fuzzy. As I mentioned, the pelvis is comprised of 3 fused bones on the left, 3 fused bones on the right, and the sacrum in the back, which joins them. Of course, we say that the hip bone or the coccyx is the non-axial pelvis. In blue above me, we see the blue head, the blue ribs, and the blue spine. And the coccyx and the sacrum are part of the spine. So that part of the pelvis that is not the coccyx and sacrum are the hips. Okay, let's look at this anatomy from Gray's Anatomy. And what we see in these red regions are the areas of insertion. There's really very little unused real estate there. And this tells us that there are a lot of muscles powerfully touching on the pelvis. The pelvis is so important for controlling posture, movement, and everything. It's no wonder that it can get out of alignment. Looking from the outside, the blue ball socket, Those are all the insertions that we talked about in the previous 6 slides. And looking from the medial side, even more. There's a lot of other insertions. The cartoon to my left shows how busy this area is. It really is where all the HVAC, all the commuting, everything's going through here. We have the large vessels, arteries, veins, nerves, lymphatics, muscles. We have the sex organs, the organs of elimination, of micturition. It's a busy place. Okay, finally, we talk about the hips as a region. And that's commonly what people will say, oh, my hips hurt. Well, where do they hurt? We can kind of break down what the diagnosis is by the location. So if they hurt in the front, it could be a hernia. Hernia is caused by the stuff in the abdominal cavity herniating down. So we have this inguinal area from the top of the pelvic crest down to the pubic bone, more common a little bit in men, and you can get a pouching and a pushing down. The doctor will ask you to cough, and they can feel up where the testicles initially descended is where this pouching will be, and that can cause hip pain. A little more common in women is the femoral hernia. That can come down through where, as we'll see in a little bit, the nerve, artery, and vein come through the femoral triangle. This can cause a bulge and pain, but that's fairly easy to distinguish. Another thing that you need to think about and consider is it could be pain at the insertion of these tendons. A tendon, you'll remember, is a muscle attaching to a bone. Okay, a ligament is a bone attaching to a bone. So shown in the top diagram above is one of the quads. This is the rectus femoris peeled off. That hurts. It's usually not like that, avulsion. It's usually a tiny sprain that will cause point tenderness in the front of the hip. The other two heads insert on the pubis. There's the the vastus lateralis and the vastus medialis. That could hurt. And if the gracilis, also inserted on the pubis, is injured, that can hurt as well. But usually when we talk about frontal hip pain, we're talking about problems at the ball socket or the neck. Okay, so let's look at the top. In the circle, we see an illustration of osteoarthritis. If we live to 250, we're all getting osteoarthritis because the original parts are not usually going to last, unless we can fix it with the things that we're talking about. What we see depicted there is it's not white and shiny. It's not thick Teflon-coated cartilage. It's kind of eroded, pinkish. We saw that well in the knee cadaveric picture last week. We also see scalloping, or we see osteophytes or outgrowths of the bone. On MRI, we can also see cysts or subchondral edema. This is all bad. It's wear and tear. To the right, we have the labral tear. Just like the shoulder has a labrum that can tear and the menisci in the knee can tear, this fibroelastic ring that supports the moving joint can be torn. At the bottom left, we have a neck fracture. Very important. Patient has pain, they get an MRI. That's usually where it's diagnosed. It's important. Maybe there are some mitigating medical things that we can do to make the bone healthier. But if it's on the point of fracture, especially in a more frail osteoporotic woman, probably want to put a pin in there to prevent that fracture, because fracture is kind of a catastrophe. Not only can it cause other trauma, it's a prolonged hospitalization with a lot of morbidity, and it can cause what we're seeing to the right, avascular necrosis. If the femoral neck breaks and it damages what's called the medial circumflex, then you get a dead head, okay? And so that dead head will be very, very bad. And this is what you see here is depicted a fix. They'll take the fibula, a little fragment of it, and vascularize it and put it in there just like a pin would be. But the advantage of this over a pin is it brings blood supply into that head in an attempt to save the head. This can also happen with dislocation in younger people. If you leave it longer than 6 or 8 hours, you can get death of the head of the femur. If the pain hurts on the side, you say, oh, doc, it hurts on the side. This is usually in active people, runners, people who bike. It's often trochanteric bursitis. So that's a fancy word. Let's break it down. The trochanter is that bump that you feel on the side of your leg. Okay, that's where a lot of the muscles insert and where the iliotibial band, that stripe, that racing stripe on the side goes down. When that hurts from this constant irritation, it's the bursa is irritated. The bursa serves to lubricate. It's that fluid-filled bag that kind of lubricates. When that hurts, you get lateral hip pain. This can be remediated with rest and physical therapy. If it's prolonged, it's damaged over a prolonged period of time, it can become really tight. And you test this with the cartoon above, Ober's test. You have the patient lie on their side and you extend their leg back, flex their knee, If the leg won't drift down and meet the other leg because the iliotibial band is tight, that's a positive Ober's sign. Finally, if the hip hurts in the back, it's one of two things usually. It's either the piriformis syndrome that we talked about in webinar 2 that can mimic sciatica. That's one of those powerful, as you see above, external rotators. That can be irritated and it can be remediated with physical therapy. Another common reason is sacroiliac joint dysfunction. Um, Sacroiliac joint, is this union of the two fused coxae or hips to the axial spine. And this was a very common thing during pregnancy. I used to tell partners to massage back there for the pregnant lady because it often hurts. And why does it hurt? Because the body blossoms open. Just like the head of the baby can be soft, the pelvis blossoms open like an expanded mechanical diagram by virtue of a hormone called relaxin. So the cartilage that is sort of that temporary rubber glue just melts so the whole pelvis can deconstruct and become disassembled to let the smart baby through. Sacroiliac pain can be exacerbated by joint discrepancy. Of course, if you have one leg that's longer than the other, the forces are applied unevenly, and that can cause further laxity, separation, and pain. And finally, lumbar fusion, it's always a Faustian bargain. You don't run the risk of catastrophic injury, and there's a little less pain from decreased motion. But what happens when you immobilize one segment, in this case, the lumbar vertebrae above, you have an increased load above and below. Yeah. So if you immobilize, let's say L3 to 5, then the sacrum is going to have to take more of that pressure of twisting and bending, and etc. Finally, we have the snapping hip. The hip can snap. The patient can reproduce this. There's three varieties, generally speaking. There's the one on the left is internal. So this is the iliopsoas tendon, snaps over this little iliopectineal eminence. It's just a bump on the pelvis below the inguinal ligament. Snaps, and the patient can reproduce this. It can also be thought to be snapping over the head of the femur as well. If it's external, it's because the iliotibial band is snapping over that greater trochanter. And if it's internal, it's the snapping is because of the labrum is torn, and it's just like the knee snapping and clicking. This is a very busy and obtuse kind of slide, but I think this is the heart of the matter, so to speak. If the heart is the center of the circulatory system, the pelvis is the center of the motion system. The X blue up on the left, the blue X, is not really an X. It just reminds us that you can get this condition of a forward pelvic tilt if you have weak abdominals and weak glutes. So what you have is you have a tight back and tight hip flexors, like the iliopsoas that we talked about in webinar 2. There's traction down and forward, right? But there's not that counter rotation, in this case, backwards, so the pelvis tilts. This kind of lordosis is shown to the right in these reversed image brown silhouettes. Pelvis is tilted forward, again, because of weak abdominals and weak glutes. So do your sit-ups, do your squats, that will tilt the pelvis back. You need to have equal force rotationally to have a good posture. Pelvis can also be tilted posteriorly too much, and that causes a flattening of the low back. The pelvis can be tilted posteriorly or anteriorly, but if it lunges forward way in front of your feet and your head, then you get this pelvic tilt with sway back. Okay, in this case, this is showing the hips are hyperextended, they're going back, the knees are extended. Bad posture will lead to further problems in the hip and low back. The neutral pelvis is shown there. Your pelvis sits above your feet, and they all sit below your shoulders, and your head is above that. This is ideal. What's shown in the girdle lady is that allegedly the same lady wearing a girdle, everything tightens up. And that's important because the tightening supports that pelvis, keeps it from rotating, from causing misalignment, from having poor posture. I want to just kind of turn you on to this picture to my left. I think this is really key, and this ties into webinar 2 with back pain. We talked about that iliopsoas syndrome. And so what we have in the top is a normal sequence. If you have strong abdominals, they work together with the iliopsoas and the rectus femoris to lift that leg off the examining table. If, on the other hand, you have a weak abdominal muscles, guess what's taking over? The psoas muscle is helping the rectus femoris. And in doing so, The stomach muscles are not keeping that pelvis stable, so the pelvis rotates forward. I think this is what we're seeing. This diagram from a website, deansomerset.com. What we're really seeing in a lot of people with low back pain is weak abdominals and glutes. We're seeing an anterior tilt, a lordosis, and we see a spondylolisthesis, or the discs, because they're being yanked on so forcefully by that overzealous psoas, they can get sliding out of alignment. Okay, so what is the girdle? I don't want to pick on only the ladies. Here's a guy with a girdle, and you can see that tightening is important. And why is it important? We'll look to the left. We see the abdominal muscles, the midline rectus, the internal external obliques, and the transverse abdominis. They all insert on the pelvis. The pelvis is where it's all happening. If you have tight, strong abdominal muscles, that pelvis is going to stay fixed and your posture will be better. On the back side, we have the erector spinae, which are the ones that straighten the spine or let you do a back bend. These are also powerful muscles. There's deep ones, there's superficial ones, and then there's this one in the low gray where we see it's called the quadratus lumborum. These can be damaged as well. So you want that tight girdle in your core. What is the core? The core is these postural, abdominal, and back extensor muscles. Okay? Finally, we have conformation. That just means how are things aligning below? Of course, we can have deformations of the feet. We can have flat feet, or we can have high arched feet with the imprints shown there. At the ankle bone, we can have the neutral in the middle, but we can also have pronation and supination. This will give different force vectors. We see the knees can be normal, or they can be bowed or not. And this comes through really well in the diagram to my left. So what we see is that in the blue, it's normal hip angle, normal knee angle, okay? When you have a varus, coxa varus, or the femoral head is overangulated, it's like a 90 degree in red there. Varus means curved towards the center, okay? Then that will create the opposite, genu varum, or valgum, okay? So varus curved towards, valgum away. So 90 degree at the hip will cause knock knees. Jump over to the right, we see that the coxa valga, meaning this obtuse, let's say 160 degree angle at the hip, will cause bow legs. The knee, coxa valga away causes, coxa valga causes genu varum, right? So this conformation causes bow legs. So it's really important to get good orthotics, understand your own body alignment, and prevent injury that way. After moving to Hawaii, I noticed there are a lot of people with gait disturbances. There's a large indigent population, and there are a lot of elderly people. And so I see a lot of this. In the Blue Man group up there on the left, we see normal walking. We see antalgic walking. In this case, they call it coxalgic walking because the hip hurts. But if you have a sprained ankle, knee, or anything on that side, you're going to favor the right. What we see is the person favors the right and they can swing their arm. That's a painful gait or a limp. The Blue Man to the right, what we see is damage to the right hip this time. The right hip hurts, and this is the Trendelenburg gait. So what we see again is that the abductor, the one that keeps the torso from falling inward, is not working. The hip sags and the body tilts. Common gait seen in this injury. We also see below, we talked about the adductor or the flexor being injured. You get the circumduction, the leg swings around. In the middle, we see an orange leg, that's high steps. This is if you have weakness of the dorsiflexion of the foot. We see this Grateful Dead Keep on Trucking lady. If she has a weak glute, she'll have to lean back on heel strike with that affected side. And we see Parkinson gait as well, this kind of shuffling, looking down, poor posture gait. So what can we do? Well, Ben Franklin makes an appearance. An ounce of prevention is worth a pound of cure. But what does that mean? I really, in doing preparation for this webinar, I really realized the importance of posture. I never really took it seriously, but of course I'm dealing with people who are very injured. And if there was any way to prevent that, I think it's important to do. So do those calisthenics, do those core exercises, strengthen them. If you think there's something out of alignment or a problem that's bothering you in your hips, go see a physical therapist. They might see something and recommend something. There's also a lot of free resources on the internet that can help you. Be careful because there is sometimes confusion of the terms, the different tilts and sway back, and not all advice is the same. So get your range of advice from different people. Um, Orthotics, custom orthotics for the feet are very important to help that conformation, and important to that you do proper technique. If you're doing squats, make sure that the knees are aligned properly. It might be worth it to talk to a physical therapist and or trainer, or consult YouTube videos to get proper alignment. Because once you start injuring stuff, then you get into this other phase, which is rest, ice, compression, elevation. And we're kind of kidding ourselves that this stuff is helping. What's really helping is, just like you need rest days after working out, it's your body that's really doing it. It's time plus your immune system clearing damage and your stem cells creating stronger, newer tissues from the inflammation. So again, we see that going through life in a healthy way, living pain-free without medications, is about maintaining that constant stress balance, low-level damage repair. Um, Finally, mesenchymal stem cells will totally 100% cure your problem. Now, why do I say that? I'm not advocating that I give you an injection. I'm saying that what we know about the basic physiology of healing is that your stem cells will come in there, the MSCs, and as shown in the diagram above, MSCs can differentiate into muscle, bone, cartilage, nerves, blood vessels, etc. What they mainly do by virtue of your natural MSCs and your exosomes is that they reprogram the cells there. They make them act younger, regenerate, shut down inflammation. That's shown right above me. Exosomes from MSCs, this is actually a slide created about MSCs, they decrease inflammation, they decrease degeneration and cell death, they decrease osteophytes, and they increase immune suppression, right? So they shut down that inflammation, like we talked about with my gout last week. I really urge everyone, if you haven't seen it, to watch webinar 5. It really clears up the whole history of regenerative medicine therapies in the joints. We talk about sugar injections, steroids, and we talk about prolotherapy. And it's important to understand that what we're talking about is itis versus osis. Itis means it's irritated, it's inflamed, it's trying to repair. Osis means it's burnt out. The telomeres are short, there aren't many stem cells, the ones that are there can no longer copy. That is what the mechanism is in arthrosis, which is a commonly used term in these MRIs. When I look at their hips, they say arthrosis or spondylothosis. Um, Tendinosis, we'll talk about extensively next week. Osis just means you've given up, you're burnt out, you're a 72-year-old civil servant, you're phoning it in, you can't help repair anymore. So go see Arnold Kaplan. He's one of the founding fathers of MSCs. If you want to understand, well, what is an MSC? Nobody really knows, but he is less ignorant than the rest of us. So these MSCs are improperly named. In fact, he wants to call them something else now, even though he coined the phrase. He wants to call them medicinal signaling cells. So what we're doing with the injections is we're taking the exosomes from a young newborn placenta, and we're giving them to you, hopefully to coax the natural repair that happens every day in every way all throughout your body. So MSC exosomes from you are doing what they can. We're trying to theoretically give them a boost. If you have a tear, you can do arthroscopic surgery, which is minimally invasive. And then, of course, the final common pathway to bad hips, extensive arthrosis. Say you have repeated bouts of gout, you're going to need a hip replacement. That's shown to my left. They put a new stem in to keep it fixed, new neck, new ball, and if it's a half hip, that's it. If it's a total hip, they replace the socket as well. Exosomes, I should reiterate, are not FDA approved to treat hip problems, even though you are using your exosomes to treat your hip problems as well as you can. My first case is TF, a guy I've known for over 20 years. He had post-surgical pain. Last year, he had a hip replacement. He, at age 12, hurt his hip. He said they used something called leather pins in his hip, which they removed at age 15. So he never really had a perfect hip. At age 49, he had it replaced. And then since the surgery, he had this pain in his posterior hip right below the iliac crest, right? Just above and to the side of the glute. I thought this was the glute medius. Initially, I kind of thought maybe this is his back pain. So he came to me. We fixed his shoulders, infraspinatus. That's now good. And we put some in the lumbar epidural. I think it helped his back pain. Again, back related to posture and pelvis. But I kind of was remiss. I didn't actually treat the place where his finger was pointing. The finger sign is, they'll tell you exactly where it is. So a day or two before coming to Hawaii, I visited him in his hotel and I injected that area. And the pain went away after a couple of days and it remains gone. Why did it hurt there? Well, when you have a hip replacement, this is shown from the front, they have these retractors in place. They don't always, or they can't, let those retractors relax. So for a couple of hours, it's pulling on the muscle, causing pressure necrosis, devascularization, denervation. So his muscle was damaged from the hip replacement, we presume, and hopefully his body repaired it with the help of exosomes. Case two was my first hip patient, AD, 66-year-old, severe disease. She really very active lady in every way, and the wear and tear had shown on her hips. I'd known her for many years. She had been a TA65 patient. At age 62, or 4 years ago, she went and saw an orthopedic surgeon and spent a bunch of money. What happened? They took out fat from her bottom, and they put those adipocyte-derived stem cells into her joint capsules. Okay, so this helped a little bit, and she had two more injections off the shelf this time, allogeneic, probably donor MSC from a placenta. She said it got better, but after a year, she said it was kind of back to baseline, which is pain at night, really making it difficult to sleep. So severe disease. And this is borne out by the MRI a year after those three stem cell treatments. The MRI report reads arthrosis with grade 3 to 4 OA. And that means she has osteophytes, subcondylar edema. She has modeling or rattiness of the cartilage, thinning of the cartilage, labral tears. I mean, she really has the trifecta, and she has effusions in the joint. In addition, as if that weren't enough, she had levoscoliosis, curvature at L3, and at L4 to 5, there's a relative sliding forward of L4 to L5. Again, hinting at these iliopsoas pulling so strongly and getting poor alignment, which, as we talked about in webinar 2, can lead to spinal stenosis. So she was really at her wit's end, wanting a total hip replacement just to ameliorate the pain. In June of last year, we did treatment with exosomes into each hip joint capsule. And we also treated her L4 epidural and a little bit into the pubic symphysis because she had some pain, perhaps from a tendon insertion there. We repeated the treatment in September. There was some slight improvement. For her third treatment, she went to another provider who gave exosomes, but this time with stem cells. And she said that, after that, by the spring, she was 90% better. I remember just being so happy. She said she was salsa dancing, body surfing, really very good. Good result. So she's a total believer, but the cost became prohibitive. And over the last 6 months of quarantine, she's had a lot of stress and had to do a lot of physical motion, walking up and down stairs, exacerbating it. She says it's back to an 8 out of 10 at times, and she can only manage it with a non-inflammagenic diet of grass-fed beef. What I show here is that the two arrows above, you can always call it the arrow sign. This is what a normal labrum should look like. It's a triangle of cartilage and surrounded by the joint fluid in the white. Go down below, we see the two arrows showing that there is no nice triangle surrounded by white. We have this sort of leakage in. That's a torn labrum. To the right, we're reminded of that femoral triangle formed by the inguinal ligament, the sartorius laterally, medially the adductor magnus. This is where all the HVAC goes through, if you will, and the electricity. You got the nerve, the artery, the vein, empty space, and lymphatics. Do not want to be messing around in here putting needles. You can cause some serious damage. So this is the one technique I insist on using real-time ultrasound guidance. What you do is you have a patient frog leg, you find the femur and the neck, and you can see the needle as it enters the tip of the skin. You turn on the Doppler flow and any significant vessels you can see and avoid. So you follow that needle all the way down. It's not that deep, and you go right into the joint capsule and you inject the fluid into the joint capsule. Case 3 is a fascinating case. It kind of proves you don't need to actually put it in the right space for it to work, because these things are 100 nanometers, they go everywhere. So AR was a 26-year-old man who fell 5 stories. Kind of landed like that, I guess, and he hit both his wrists, shattered his pelvis. The forces transmitted and shattered six vertebrae. He actually needed CPR for 10 minutes because he went into arrest from the shock. So luckily, he didn't have any traumatic brain injury. Very brilliant, very athletic. He's a dentist, and so he ended up getting this fixation. This is not him above, but it's illustrative of what the hardware would look like. Fixating the spine, because if you don't fixate the spine, you can get excessive motion and paralysis. So they had no choice. Unfortunately, the field got infected. He had to be reoperated a few months later because of terrible drug-resistant infection, and they had to replace all the hardware. Thankfully, they had to go a little higher, T8, all the way, thoracic 8, down to sacral 1. But now it's in place, it's not infected, and he's making a great recovery. I was really amazed and inspired by his recovery. When I saw him literally a day before I came to Hawaii, we did treatments. We only got 5 billion IV, and there were really no effects for 4 weeks. In the fifth week, he did report back to me this a couple of weeks ago. He said his back pain had decreased from an 8 to a 4. I can imagine living with chronic back pain 8 out of 10. And his wrist pain, he still has hardware in the right wrist, went from a 6 to a 3. So I was very pleased to hear that there was a late onset of whatever was regenerating took a little time. But most significant is that he had a baseline, and this is after an amazing amount of recovery from this fall, which is right at the lethal dose. 50% of people die from a fall of that height, 5 stories. So he had terrible weakness in his right hip. He was limping, and at that time, it was quite noticeable. But he and his therapist both said that his strength in his right leg and the hip were 70% better, which was very, very gratifying to me. Last case is Colleen. She's on the line. I hope she's still on the line. She is a neighbor. She's right across the street. And by some serendipity, a friend of hers who no longer lives here said, "You should follow Dr. Park. You're really lucky. He might be able to help you." Colleen is a 66-year-old, very active lady. She had severe hip problems and back problems. So, again, reminding us that the hip and the back are working together. The MRI above me is actually hers. The pelvis x-ray is not, but it's kind of indicative of what she would have had. In the back, we see that white cone, that's the spinal cord, is pinched right there at L3 to L4. It's pinched. And that the L4 vertebrae is kind of mottled. It doesn't look like a nice cylinder, like a marshmallow. It's sliding forward, and the cartilage above and the cartilage below is mottled. It's not a nice round black disc. Okay, so the radiologist read that as L3, L4 degenerative disc disease and subluxation. Yes, we see that it's sliding forward. And then we have L4 to L5 degenerative disc disease. Interestingly, the disc is, or the vertebra is so unstable that although she's had sciatica, meaning nerve root pain on the right for the last 4 years, for 2 to 3 years before that, it was on the left. So that disc is sliding all around. Again, reiterating the importance of disc stability from the ligaments, from not having that iliopsoas pulling on it, good posture, etc. Her right hip ball disease is kind of, this is not her again, but it would look like that. There's decreased cartilage, there's osteophytes, subcondylar edema. Interestingly, that pain, like the back, is about a 5 out of 10, but she's very active. She's done more, tried it all in good faith, yoga, healing, Reiki, uh, all these things I can't even remember, Ho'onopono. She really is very active. She really leaned into therapeutic alternative stuff. But unfortunately, not in every case was it helping. Sometimes maybe adding injury. Very passionate about yoga, very passionate about exercise, and even still to this day walks 2 to 4 miles a day. Very good health, very good conditioning. So nothing really to blame her about. Interesting, on exams, we have these, under the nail, we have these distal interphalangeal joint, or the knuckle, were swollen, especially on her right hand, I believe. She was never tested for rheumatoid factor, and rheumatoid arthritis typically causes these Heberdine's nodes, or these Bouchard nodes, that's the middle knuckle. She has low thyroid, and she's a little hypogonad, meaning natural menopause was followed by estrogen for a while, her doctor retired. There was some miscommunication with the pharmacist, and she kind of just took the progesterone, which is not the part of the hormones that prevents osteoporosis. So all these things kind of conspired. About 6 or 7 weeks ago, she came to my office. She was kind of, at that time I didn't have a yoga mat, so she walked across the street. We did the procedure both in her lumbar epidural and into her right hip joint, and she was able to see the needle going right in the joint capsule and the fluid expanding that little tissue or that little sac of fluid. Unfortunately, the hip is not any better. It hurts, it's sore, but there was one good sign, which is that there was a heaviness. And unless you felt this, you really don't know what it is. It's a feeling of increased gravity or gravitas, if you will. I talk about it extensively in blog 27, and this is a very kind of pathognomonic or specific thing that we see in people when the exosomes are working. It's a recruitment of energy or chi or prana or white blood cells or whatever you want to call it. There's just something going on. It's heavy. Not painful, but just heavy. But the good news is that the depression in her back from whatever was happening filled in, and that her sciatica is resolved. So whatever's going on there maybe is tightening up the inside mini girdle of those ligaments of the cartilage. It's realigning, the muscles are relaxed. Whatever we did in L4 may have contributed to improve both the inflammatory milieu and the regeneration of ligament, cartilage, muscle, fine muscle. So we can hope or maybe infer that it doesn't look like that inside anymore, and there's not that nerve root compression. So I want to thank everyone for attending. I just want to remind people that, the more I learn about exosomes, including my own need for repeat exosomes, the more I realize that sometimes people just give up and they shouldn't. Because really, what else is there out there other than, a time machine to make you repair? Again, as I say, your MSCs and your MSC exosomes are trying, but they come from an older, more damaged source. What we're doing is taking newborn MSCs and giving you a better shot at repair, we hope. A person who says, hey, it's only 30% better, that's 30% more than you would have gotten from any other treatment. I think prolotherapy, as we talked about last week with gout, is dancing with the devil because you're causing more inflammation in the hopes of gaining some kind of repair from the response. So, a lot of people, myself included, they say, well, it doesn't really work. The thing came back. Well, guess what? You were alive for 15 months. You know, the nagging knee pain from the torn meniscus came back, so I had to repeat the injection. You don't really go and say, well, my car was dirty. I washed it, but it didn't work because the car got dirty again. You're still using these things. There's still underlying damage. Nobody's saying you're going from 20% function to 100% function. So it's important to maintain what you can. It's important to consider that if it worked, then it didn't. It's not a failure. You just didn't go to 100%. You might have to do it again or ongoing. So don't give up. Next week we'll talk about tendon problems, and I want to again thank you for attending.